Welcome to another Puscast. This one is covering the first 2 weeks of August 2011, and since it is no longer CME accredited, I don't have to do the usual blah-de-blah-de-blah. This is being recorded outside on my front porch. While the rest of the nation has been sweltering, it has been the year of the green tomatoes in the Pacific Northwest, and today it's going to be 90. I am not going to sit inside and do this podcast. So you'll hear extraneous sounds such as the wind in the willows, the sounds of cars going by, the thump every 10 seconds as my Japanese bamboo fountain fills and empties. Very Kill Bill. But we'll move right on to the podcast. And I know that when you're done, you're either going to go to my website, where you will find all the links to the Mark Crislip Growing Multimedia Empire, or, more importantly, you are going to go to iTunes and write me a glowing review. And this is my first Puscast using a Yeti microphone and sound studio instead of GarageBand. So we'll see how well it works, but I just got fed up with GarageBand. And this seems to be doing well for me. Let's move on to the literature as the wind goes through the maple trees. Remember, of course, all the references are available at the website. So perhaps you're wondering about arena viruses, not arena football or arena soccer. The arena virus consists of lymphochorial meningitis virus, which causes lymphochorial meningitis. There's the whitewater arroyovirus and other members which go under the Tacribe, T-A-C-A-R-I-B-E complex. It includes the Bear Canyon virus, the Big Bushy Tank virus, the Katrina virus, the Rio Catorce virus, the Skinner Tank virus, the Tonto Creek virus, and your favorite of mine, the Miami virus. These all exist in the North American subcontinent and are associated with various and sundry animal vectors. This study looked at febrile illnesses and lymphochorial meningitis in a wide variety of human beings, specifically 1,185 persons who had acute central nervous system disease or an undifferentiated viral illness. And they found that the Tacribe, T-A-C-A-R-I-B-E, serocomplex virus was a common cause in this group of febrile illness. Which one? They wouldn't say. But there are far more viruses out there that cause febrile illnesses and encephalitis meningitis than we can usually diagnose clinically. Cowpox was found in an outbreak in Italian llamas. Probably got there by way of a German mongoose. Why do you care? Well, since people no longer have smallpox vaccination, they are at risk for developing cowpox. Cowpox is found throughout Europe, and not only in cows, but llamas and cats and other zoo-related animals and livestock animals. So you need to watch for cowpox in patients with animal exposures. In normal people, it causes self-limited localized disease, but can spread in those that are immunocompetent. So beware the llama. Wasn't that a Bruce Lee movie, Beware the Llama? Probably not. As often seems the case, what I don't know far exceeds what I do know. I have never heard of a Merkel cell infection. Evidently, Merkel cell is a form of skin cancer. It is caused by the Merkel cell polyomavirus and is found in 80% of Merkel cell carcinomas. This is a rare but aggressive skin cancer that usually occurs in the elderly and immunocompetent patients such as AIDS. But what, you might ask, is the clinical manifestation of acute Merkel cell polyomavirus? Well, they looked at a bunch of gay and bisexual men over time and found that patients seroconverted at a rate of about 7% per year. They had no symptoms of their infection, and it was not associated with any AIDS progression or worsening of HIV. So it would appear that developing a Merkel cell polyomavirus infection is common. It's usually asymptomatic, And it does put you at risk down the line, perhaps, if you get immunocompetent or old, developing one weird-ass named cancer. Maybe this should be called the Weird-Ass Virus Podcast this month. This one concerns the Pumala virus, which I've never heard of. It is evidently one of many hantaviruses. This one is found primarily in Northern Europe, but like other hantaviruses, its range may be changing with global warming. This particular virus causes a renal syndrome with hemorrhagic fever, and as I said, is found primarily in Northern Europe. It's spread by the bank vole, so be careful when you're putting your money in that Swiss bank account to hide it from the feds. The bank vole may give you Pumala virus. Anyway, this study looked at who's at risk for certain complications, and they found that the people who primarily get CNS complications due to Pumala virus are young male patients. More evidence, perhaps, that men are different than women. We die with Pumala virus. And as long as we're still talking about viruses, there was a CDC report of a patient who died of rabies in Louisiana. It turned out to be vampire bat rabies, and the patient had been bitten whilst in Mexico on the heel by a vampire bat. This is of interest because bats, like vampire bats, which are found in Latin America, could come north with climate change, and to date the Homeland Security has not been noted for its ability to keep these unwanted infections out of the United States. We can get rid of bin Laden, but we can't get rid of vampire bats. What the hell good are they? More novel viruses. I prefer short story viruses. Two kids had the unfortunate event of developing an acute necrotizing encephalopathy in France. They looked for the reason, and they found a novel reovirus as the cause of the poor kid's brain encephalitis, though where else are you going to get an encephalitis? And they think it was closely related to a porcine reovirus. This is unusual in that at least half of humans have antibodies directed against reoviruses, but most do not have any known clinical syndromes. One wonders, that one being me, if because it occurred in the same family, there was some immunologic defect that led to their inability to deal with the reovirus. As I have said many times, get off my lawn, punk. Actually, what I have said is there is no disease for which steroids have not been tried, with the possible exception of Cushing's, and I bet you people have tried it for Cushing's. This was an article in Clinical Infectious Diseases that looked at the outcomes with the early use of steroids in patients with critical disease in H1N1. And guess what? Them what got steroids died at much greater rates than them what didn't. What were those relative death rates? Well, 71% of those that got steroids developed either death or a critical illness, and I always think that death is a critical illness. Whereas those that didn't get steroids, 39% developed critical illness or death. About half if you got no therapy as opposed to if you got steroids. Steroids kill patients with H1N1. Don't give it. Unless, of course, they have Addison's disease. Then maybe it's worth it. This is now, I think, the second or third trial I have mentioned in this podcast, analysis of the use of steroids with H1N1, and all have shown increased mortality in patients that got steroids. I learned a long time ago, but I wish I had a reference because I don't, that if you try a therapy for which there is no proven efficacy, the chances are higher that you will do harm than you will help. Now, I don't have a reference for that, and that could be totally erroneous. But still, it's my podcast. I'll do what I want. There was a trial in the Annals of Internal Medicine this month that compared oseltamivir with a Chinese traditional therapy for which they do not provide a pronunciation guide. And they found that the Chinese therapy without the pronunciation guide was more effective than oseltamivir for decreasing flu in patients with mild H1N1. I'm going to rant on this particular paper at length in an upcoming Quackcast, and it will be the topic of my next science-based medicine blog entry. So if you're going to want to find out what I thought of that article, you're going to have to read SBM or go to my Quackcast. It's like a newscast teaser. Common household items that can kill you immediately. Details at 11. It always comes up in seropositive discordant couples, one of whom has HIV, what the risk of transmission will be in someone who is virologically suppressed. This study looked at almost 1,800 serologically discordant couples with HIV, and about half of whom were in Africa, and they were randomized to get either early anti-HIV therapy or more standard later therapy. Early therapy was when the CD4 counts were between 350 and 550. And they found a marked decrease in HIV transmission in the group that had early therapy when compared to those that had later therapy. There was one transmission in the early treatment group versus 38 transmissions, 28 of which were linked to the partner in the more standard therapy group. There were, not unsurprisingly, more toxicities in the group on antiretroviral therapy, but the lack of transmission in discordant couples was phenomenal. Now, there are also issues to be determined as to other techniques to prevent transmission of HIV, such as condom use, and that was not addressed in the article. But still, it's quite impressive, the decline in transmission that occurs when you treat one of the seropositive patients with HIV medications. The take-home message is that early therapy prevents transmission of HIV, but it does not suggest that, as a consequence, you should not use condoms. And a gene that is associated with psoriasis, the CCHCR1 gene, was looked at, and if you had polymorphisms in that gene in a Thai population, you were more likely to have a reaction to nevirapine. As Shakespeare said, the answer lies not in the stars, but in ourselves. Yet another polymorphism that is associated with an increased risk of disease. Exact causality yet to be determined. One of those recurring themes in this Puscast is the widespread problems with hepatitis E, yet how rarely we look for it in patients. Something like 20% of Americans are seropositive for hepatitis E, yet we rarely send off the serologies. There's a case in France of a polyradiculopathy that was associated with acute hepatitis E. The take-home, I think, is the alphabet does not stop with D. Thank you, Dr. Wakefield. As you probably or may not be aware, Dr. Wakefield published an article in The Lancet a bunch of years ago that purportedly linked the MMR to autism. He was subsequently retracted from The Lancet because basically he made the whole thing up. Subsequently, however, measles rates fell in England, and in 2003, vaccination rates in London were at 61% in some sections of the city. They had risen somewhat by 2008. I can't find the exact number, though I find allusions to the fact that the vaccination rates were still low. A German from Hamburg went to London in 2008 and brought measles back to northern Germany, a total of 288 cases. Then it went from Hamburg to Bulgaria, where there were 25,000 cases, more than had been seen since the Ukraine in 2006. So again, thank you, Dr. Wakefield, for giving us an outbreak of measles. Noro is a common cause of gastroenteritis, and there is a new strain out there, the G2.4 Minerva strain. Used to be the common cause of gastroenteritis due to norovirus. Now it's the G2.4 New Orleans strain, which is now accounting for more than 50% of outbreaks of foodborne norovirus in the United States. This is demonstrated by the CaliciNet, which, contrary to its name, is nothing to do with capturing Dothraki queens, but rather looking for the cause of norovirus infections. For those of you that do not know what Dothraki queens are, well, you lost all nerd credit with me. In Georgia, they used molecular techniques to look at the cause of acute gastroenteritis. And they found when they used standard testing, they found noro in 7%. But when they used molecular testing, 15.7% of gastroenteritis were due to norovirus. That's a very common infection. I do not normally talk about pediatric stuff, but I do have a passion for vaccines. And an article in Pediatrics looked at varicella deaths in the United States after the implementation of the single-dose varicella vaccine. And death rates due to varicella fell dramatically from 0.41 per million to 0.05 per million, which is very impressive. By the way you can always tell someone is an anti-vaccine wackaloon is when they say the death rate due to varicella is only 0.05 per million or only 0.4 per million. Anybody who sees the deaths of children as an only is an anti-vaccine wackaloon. I like that term, wackaloon. I think it's Australian in origin. And it does have a correlation with whack-a-mole, because no matter how much you refute the wackaloons, another one comes up somewhere else. So there's a state in infectious diseases that I have always referred to as a doxycycline deficiency state. They're patients who have multi-organ system involvement. Are there clinical differences? Often with a cytopenia and elevated transaminases. That tends to be things like Ehrlichia and Rickettsia and Q fever, things you can't routinely grow. So occasionally you get a patient who comes in sick and you can't figure out what they have, but the overall clinical pattern says they have a doxycycline deficiency state. One of the causes of a doxycycline deficiency state is ehrlichiosis. And the two Ehrlichia in the United States that classically cause illness are Ehrlichia chaffiensis and Ehrlichia Ewingii, E-W-I-N-G-I-I. You know, these things really need a pronunciation guide. Anyway, there were 4 patients in Wisconsin and Minnesota who came down with what? Fever, malaise, headache, lymphopenia, thrombocytopenia, and transaminitis. They all had a doxycycline deficiency state, and it turned out to be due to a brand new Ehrlichia never reported before. And evidently they didn't take the opportunity to name the Ehrlichia after themselves, or at least the patient that was infected. It was mostly like an E. muris, which is an Eastern European and Japanese Old World Ehrlichia. So there are Ehrlichias all over the place. New ones, old ones. They're always called novel. So here's another novel infection. We've had arenaviruses. We've had other viruses. Now we have a novel Ehrlichia. I wonder if they come in audible book form. Bell's palsy. It can be due to Lyme. It can be due to herpes virus. It can be idiopathic. Can you tell the difference between a Lyme Bell's palsy and a non-Lyme Bell's palsy? Allegedly, yes. The study looked at a bunch of patients who had Bell's, some of whom had definitive or possible Lyme, the rest of whom did not. So the difference was as follows. Lyme-related Bell's tended to occur in August, not really helpful, but Lyme also had more neurologic signs outside of the Bell's palsy, tended to have higher protein and higher mononuclear cells in their CSF. 165 on average versus 2. And the CSF albumin tended to be 840 in the Lyme versus 196 in the non-Lyme. So there is some hints on clinical spinal tap as to a difference between the two. Fortunately, I live in Oregon, and we don't have Lyme here. So I was at our weekly infectious disease citywide meeting a couple months ago, and one of my colleagues from another system asked me, how do you use procalcitonin? So what is associated with... I said, I haven't figured out how to use it yet. And he said, we can't round in the ICU without it. For me, that would be coffee. But I still haven't figured out how to incorporate procalcitonins, much less troponins or C-reactive proteins into my practice. I guess I am a refractory old geezer in that respect. This month's CID has a systematic review of the use of procalcitonins in the ICU to guide duration of antibiotic therapy. And I will summarize from the conclusion. Procalcitonin guided and control groups did not differ meaningfully in rates of mortality, infection relapse, or days free of mechanical ventilation. Patients whose antimicrobial therapy was informed by procalcitonins had shorter ICU lengths of stay in 2 of 5 studies, no differences in the other, and no significant differences in length of hospital stay. So, at least from this systematic review, it would appear that you can use procalcitonins both safely and with efficacy in determining the length of therapy of antibiotics in the ICU. Maybe I need to finally get with the program. So, like everybody, you want to get a good outcome when you have an infected prosthetic knee or hip. The study looked at those things associated with salvage of the joint. Much to my surprise, a 1-stage procedure had better outcomes than a 2-stage procedure. But the key thing was the use of rifampin with your therapy. So you should give rifampin with your beta-lactam or with your quinolone, which was the best odds for getting a resolution of a prosthetic joint infection. I normally give 6 weeks of IV something plus rifampin, followed up by 6 months of oral something plus rifampin, usually a quinolone if I can, and patients tend to salvage their joints the vast majority of the time. It's safe to say it's always something. For example, it's been known for a while that if the MIC of vancomycin increases, the patients have poorer outcomes when they're put on vancomycin. But the interesting thing about this study is that the higher the vancomycin MIC, the higher the mortality if it was MSSA. But not whether or not the staff was MRSA. The cutoff was an MIC in this study of greater than 1.5. And as the MIC got up above 1.5, there was a 15% difference in mortality, regardless of whether or not it was MRSA or MSSA, and whether or not it was treated with appropriately a beta-lactam. So as they say, quote, this surprising result suggests that factors other than poor vancomycin efficacy per se are responsible for the inferior outcome in these patients. Now, I have been hesitant to use vancomycin in patients whose MIC is greater than 1, especially if it's 2. But even if it's MSSA, there may be issues, and perhaps we should go back to autoclave. No, that's not a good idea. Vitamins, or vitamins for my English listeners, can have important immunologic effects, and the literature on vitamin D deficiency and its association with increased infection risk is interesting, if minor, component in the ongoing battle against infectious diseases. Interestingly, there was a study that had an association between low vitamin D levels and Staph aureus nasal colonization. They postulate that vitamin D mediates the production of anti-staphylococcal peptides, and that if you lack vitamin D, you have more staph. And indeed, they did. If memory serves, and now I sound like the chairman from Iron Chef, but if memory serves, there are 2 studies that have demonstrated that if your catheter tip is positive for Staph aureus, you subsequently have a high chance of a subsequent Staph aureus bacteremia. This is not necessarily true for all organisms. This study in critical care medicine looked at 138 positive catheter cultures that had 149 pathogenic organisms, and they only had 2 bacteremias, one with an E. coli and one with the Staph epi. So perhaps other organisms do not have the infectious potential that Staph aureus does. I would still be hesitant not to treat a catheter tip that was positive solely for Staph aureus in the absence of positive blood cultures, as there's enough clinical data to suggest that anybody who has a new infection with, or I should say new colonization with Staph aureus, has a high chance of bacteremia in the near future. I was trained with the understanding that amongst beta-lactams, nafcillin was superior to cefazolin for the treatment of MSSA. Now, I don't know and never did know if there was data to back this up. My attendings told me that, well, ANSEF isn't as stable in the test tube to staph beta-lactamases, and they all had experiences early in their practice of cefazolin failure. So I was told that never use cefazolin, and if you can use nafcillin. And about 20% of MSSA will have an inoculum effect to cefazolin, i.e. high inoculums have less efficacy by the cefazolin. So this study looked retrospectively at all the patients who were treated with cefazolin or nafcillin for MSSA bacteremia, and they found no difference between the 2 antibiotics. At 4 weeks, there were 10% failure rates in both, and at 12 weeks, there was a 15% failure rate in both. Cefazolin, not unsurprisingly, had markedly fewer adverse events, 0 versus 17%. So at least in this retrospective study of Staph aureus bacteremia, cefazolin, or as my pharmacists love to mispronounce it, cefazolin, is no worse or no better than nafcillin for staph bacteremia. I am running out of time for my midlife crisis. At 54, I soon will have to have an old age crisis. Maybe a tat? Nah, they've been associated with various and sundry infectious diseases. How about a piercing? Well, unfortunately, there's a case report of somebody who had an ear piercing and subsequently got MRSA bacteremia. And it's one of several cases of endocarditis after a body piercing. So, can't get a piercing, can't get a tat, maybe a goatee, a ponytail? I need to do something for a middle-aged crisis. Anybody have any good ideas? As a case in point, there's also someone who got a tattoo, and as reported in Emerging Infectious Diseases, got a Mycobacterium haemophilus tattoo infection. You just can't get any kind of needling of the skin these days without getting an infection. Sometimes I am just drawn to the headline. Spermless mosquitoes could help halt malaria spread. So they have developed spermless mosquitoes. Why would these halt the spread of malaria? Well, I'll quote from the article. After mating for the first and only time in her life, the female mosquito goes through certain physiologic changes, then has a blood meal, and lays her eggs. So if the male mosquito is spermless, she may lay eggs, but she's not gonna reproduce. I can't help but think that it's more than mosquitoes that need to be spermless to make a better world. Or is that just me? Still, it's a clever idea. And as long as we're on the topic of malaria, there was a study that looked at the use of mannitol in patients with cerebral edema from malaria and found that it prolonged the illness, not improved the illness. So don't give mannitol to your cerebral malaria patients. Not that you were going to, but it's nice to know what the negative studies are sometimes. Is obesity an infectious disease? Well, you may remember a while back there was a study that showed the use of vancomycin during the treatment of endocarditis was associated with the development of obesity. Why might that be? Well, this study looked at the gut-associated microbiota of patients who were obese and found that patients who were obese were depleted in Methanobrevibacter smithii. They did have Bifidobacterium and Lactobacillus, which was associated with normal weight, and Lactobacillus reuteri was associated with obesity. Now, association is not causation, but it is rather curious that there may be some impact on your gut flora and whether or not you are obese. I certainly find it interesting that vancomycin, which could conceivably kill off the thinning bugs, as it were, would lead to weight gain in patients with endocarditis. But then, as you know, I think everything is due to an infectious disease or genetic or wear and tear, and that's pretty much it. I first heard Dave Gilbert give that hypothesis years ago at a conference, and I think it's right on. I try and keep this to 30 minutes, and I'm at 31:40, so I'm going to wrap it up. The only other curiosity was a report of West Nile and a whale. I just thought that was entertaining. There was salmonella passed on by peanut butter. And here in the Pacific Northwest, we had an outbreak of OH157 that was traced to strawberries that was traced to deer poo. And the deer were pooping on the strawberries and people were eating the strawberries. I only eat deep-fried food, as I've said many, many times. So that brings us to the end of the Persiflager's Puscast, a review of infectious diseases. The literature and the references are available on the website. No more CME. The rules and regulations are too much of a hassle for something I've been doing for free. Don't forget my other blogs and podcasts and books, oh my, links to which can be found at moremark.squarespace.com because the world needs more Mark Crislip. This is Created Commons License Copyrighted 2011. You can use it wherever you want. You just can't alter it and you can't charge for it. Otherwise, this brings it to a close. I'll see you next time. No guitar from my son. Talk to you later. Oh, and thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.